Good morning, everyone. Thank you for joining us for ShrinkSync Open Mic. So excited to have Sarah Vicendes on today, and she's going to be talking about bipolar disorder. Um, that I feel like a lot of us, especially MFDs, don't have a ton of training in, and I'm so excited to hear her presentation. Before we jump into that, this presentation is brought to you by ShrinkSync Open Mic. ShrinkSync is a networking platform for mental health providers, an app and a tool for us to find referrals, um, treatment facilities, events for therapists, kind of a one stop shop for everything you need. It's free to use. You can go sign up on shrinksync.com and create a profile there and then get to know and connect with fellow therapists. We always record these presentations. Open mic is something that we do where we invite members of the ShrinkSync community to present on their expertise and then provide CEs for the attendees. So, a few housekeeping um, things to note is this is being recorded. We will post it on our site and send you the recording. Um, expect that on in our Tuesday newsletter. And as soon as this presentation is over, you'll be redirected to another site which has the evaluation form. If you missed that, it'll be on shrinksync.com/open mic on the bipolar disorder presentation page. When you fill out your evaluation page, then we will send you the CE certificate. My girl who makes the CE certificates is spending a month in India in a yoga retreat. So it's usually sent out the next day or two, but we're going to give her a couple of days to do that this time around. If you have any questions, you can email me um, or you can type it in this chat box. If you have any technical issues during the presentation, I can help with that. And then Sarah's going to mention how she's going to handle um, the questions for her. But let me introduce you to Sarah. She's a licensed MFT, and she provides in-person and teletherapy services to clients across the state of California. Her offices are located in West Los Angeles and Calabasas. Her practice treats adults, adolescents, children, and couples. Her professional expertise is diverse. At the Maple Counseling Center in Beverly Hills, she received supervised training in psychodynamic interpersonal therapy. At the UCLA Mood Disorders Research Program in Westwood, she was trained in the clinical assessment of mood disorders, specializing in bipolar disorder. Sarah also trained at the UCLA Anxiety Disorders Pediatric Intensive Outpatient Program, working with adolescents diagnosed with severe anxiety disorders, including but not limited to OCD, specific phobia, and social phobia. This clinic specializes in providing exposure with response prevention, a behavioral treatment approach proven effective in treating severe anxiety disorders. As an MFT intern in private practice, Sarah provided psychotherapy services under the direct supervision of Dr. Michael Cameron, licensed psychologist and clinical professor of psychiatry at UCLA's Geffen School of Medicine. In addition to her private practice, Sarah also recently served as a staff research associate at UCLA's Child and Adolescent Mood Disorders Program. Sarah also completed an externship in emotionally focused couples therapy, and she conducts EFT. Um, Sarah earned her master's degree in marriage and family therapy from the University of Southern California and her bachelor's degree from New York University. So, without further ado, I'm going to remove myself from the presentation the screen. Somebody asked if they'll receive the slides. I can add them to her page on ShrinkSync so that you can have it after the presentation, if that's okay with Sarah.
Yeah.
Uh, and without further ado, I'm gonna throw it over to you. You can go over how you want to handle questions, and then I will help with the YouTube video as well.
Okay. Hi, everyone. That was such a thorough bio. I don't need to explain to you who I am and what I do, which will save us a little bit of time. I appreciate being here. I think it's really important what ShrinkSync is doing, especially after COVID. I know that myself and a lot of other mental health professionals felt really isolated during that time and we're kind of sitting in front of a computer screen, which is not why most of us got into this field. And so it's really nice to be able to connect, even though we're all staring at a computer screen again. This feels like it's much more connected, and we'll have a chance to ask each other questions and talk about it. And to that point, when I give kind of smaller in person presentations and trainings, it is a little more interactive, and I like to take questions throughout. In situations like this, especially where I have a lot of content to get through in a relatively short amount of time, I ask for you to save your questions for the end. I'm going to try to leave like 5-10 minutes before the hour in case you have to leave at 10. But I can stay until about 10:15, 10:20 to answer any questions that I don't get to in that time. So we can start with what is bipolar disorder. I'm going to start with a video and show about 4 minutes of this video, just because I think it's really well stated. This is Ellen Fournier, who is a comic, not a comic, a comic strip author and illustrator. And she also wrote Marbles, which is a wonderful kind of comic strip novel on her experience with bipolar disorder, bipolar 1. So let's see if I can start that.
Yeah.
Yeah.
You want to go ahead and start it, and then you can pause it when you're ready for it to be over. Okay.
All right.
Shortly before my 30th birthday, I got my first and only tattoo. My whole back.
Ooh.
And I sat under the needle.
It's not working.
And I sat under the needle for 5.5 hours
jumping around
straight.
With no audio.
It was
is that everyone
awesome.
else too?
Intense, cathartic. I was being branded in a rite of
for you.
passage, walking on red-hot coals through a flaming doorway, being transformed, becoming even more badass and beautiful. And I knew from deep down that nothing would ever be the same. As I walked home in the snow, in the cool air, on the sparkling sidewalk, everything was perfect, exponentially perfect. Everything was magical and intense and bursting with universal truth. A few weeks later, I was referred to a psychiatrist. And she had some interesting news for me. She told me I had bipolar 1 disorder, which I didn't believe.
You know what?
So
I'm gonna stop
she
it,
took out her
because if we're not all on the same page, okay, so can I hear from you, Rachel, if you can hear me now, and then we'll go back to the presentation. Okay.
Put on the presentation. Yeah.
Oh, technology. That is a wonderful, you have the link and then she sent it to you actually in the comments. That's a wonderful video.
Page as well. I'll put it up on your page and we'll share that.
Okay.
Because perfect. I watched some of it when you sent me your slides. I watched some of it and it was fantastic.
Yeah, I was going to show the first 4 minutes, but go ahead and watch the whole thing. She talks about suffering from bipolar 1, which is, I'll explain, the more severe form of the disorder. And just the way she speaks about it, I think, is really profound. You can also look up Kay Redfield Jamison. And I have her in the resources at the end of this. She is a psychiatry professor at Johns Hopkins and also wrote An Unquiet Mind and Touched by Fire. And she does a lot of online talks too. Anything by her should be pretty great online. So, okay. I like to add these quotes. I mean, this idea of what used to be called manic depression, which I actually, they shifted it to bipolar disorder. My understanding of why is because of stigma associated with manic depression as a term. Which I think is a positive thing that they're trying to it's kind of like a branding thing, if you will, to try to make it seem a little less overwhelming or stigmatized. I think manic depression actually better captures what it is. But this has been talked about, throughout. You can go way back even before this Richard Mead quote in 1751. And It's referred to by poets and authors and a lot of creative people that experience these types of ups and downs. But you know, he writes medical writers distinguish between two kinds of madness. Also, madness, not a word we really use anymore, but one that was used quite a bit in history. You know, one that is attended with audaciousness and fury, the other with sadness and fear. They call mania, this melancholy. Melancholy, a word used for depression, obviously. Virginia Woolf, wonderful author that you all are familiar with. She suffered from significant mood swings and writes, such sensations spread over my spine and head, such an exaggerated tiredness. What a way to describe depression. Such anguishes and despairs and heavenly relief and rest, and then misery again. That heavenly relief might have come from an upswing. Rest doesn't sound so much, but never was anyone so tossed up and down by the body as I am, I think. And then Kay Redfield Jamison saying, one of the things so bad about depression and bipolar disorder is that if you don't have prior awareness, you don't have any idea what hit you. And so I'm trying to give you today some awareness over what this is and what it looks like so that you can then provide that for your clients. There's often a discussion about the importance of labels or diagnoses. I understand why some of our colleagues might resist the idea of labeling people, as it feels like it might be a little bit dismissive or pathologizing. But my experience and the experience of most of my patients, especially with something like bipolar disorder, is that a proper diagnosis can be absolutely relieving and liberating. This idea, and I think that's true I speak about OCD a lot and a lot of other disorders, perhaps all of them, right? It gives some context to suffering. It gives a roadmap of, look, I'm not alone. Other people have experienced some version of this. Maybe not exactly what I've experienced, but there are ways to treat it. There are now medications that treat it pretty effectively. And so a proper diagnosis and not pathologizing it by being overly concerned with or passive about the diagnosis, just simply stating, you know, the symptoms you are experiencing are symptoms that are described and well researched within this diagnosis of bipolar disorder, and really processing what that means and moving forward with more of a roadmap for how to treat it. So when we conceptualize what bipolar disorder is, I'm a really visual person. I was on a podcast recently and I tried to do this slide with my hands and it was not working super well, because then I realized I was on a podcast and people could only hear me. So I'm very glad we have this slide now. It's just a little easier for me. So you can see that it's characterized by pretty significant mood swings. These are not typical moods. It's not the, I was so happy on my wedding day and I was so depressed when a family member passed away. These are cyclical mood swings that people will describe as very different from their normal self, really significant, very impairing, and bipolar 1 being the more significant because we reach a level of mania, which is on the upswing, which is, I'll describe what that is. You'll notice bipolar 2 has less of an upswing, less of a functional impairment, less distress, although can still be quite distressing and impairing. But you'll notice the depression is the same. And actually, in many cases, bipolar 2 can have even more severe depressions than bipolar 1. So while it is known as the less severe of between 1 and 2, it certainly shouldn't be discounted as it causes significant functional impairment, especially in the depressions. Cyclothymia is represented as still mood swingy enough to cause a problem in the person's life, but doesn't reach the level of bipolar 1 or bipolar 2. So I'm not going to just read off of the DSM. You guys have the DSM. And you can look into it. What I'm going to do is I am going to show you the criteria just so you have it in front of you, and speak to it, highlighting a couple of the things. And so when you're looking at the criteria for what a mania is, and this is bipolar 1, kind of the highest of the highs, you have this period of time where people are up and hyper and excited, more than their typical self. they typically notice, hey, something's really off here. Or if they're not noticing it, which is often the case, the people around them will notice that it is a very abnormally persistent, elevated mood. It can be expansive, so really grandiose and feeling amazing and doing, what they perceive as really life changing pursuit of some pretty groundbreaking things they're working on. Or it can be really irritable and kind of rage outbursts. And so you can have one or the other. You can also have both of the irritability and expansive mood. And they give it a time period of at least 1 week. If someone is hospitalized a couple days in, you don't need the week for that diagnosis, because as soon as someone is hospitalized or in jail, that's another thing where if their irritability got them to a place where it was specifically because of the heightened irritability, and they started a fight or they got themselves in trouble, either of those cases, or psychosis, loss of touch with reality, are going to put you automatically into that mania category. So here are some of the criteria that you're going to need for this diagnosis of mania. 3 or more, or 4 if irritable mood. I wouldn't get too hung up when you're doing assessments for research. And during my time at UCLA, we had to get pretty specific, or else the research wouldn't be as kind of targeted as we would need it to be. But quite honestly, you're going to notice, I think, most of these. It's pretty rare that you only notice a couple, and so you're going to have these extreme swings of heightened self-esteem and grandiosity. That's not just I feel really good about myself because I'm giving this presentation and it's making me feel proud of myself as a therapist, right? This is, I am amazing. I have so much to share that the world needs to hear everything I have to share, and I have to get it out there to change the world because I'm so great. Just decreased need for sleep. That is not I'm sleeping less. That is I need less sleep. So you'll hear 3 or 4 hours a night, which is different from how much they normally sleep. But I felt fine the next day, right? I didn't need to sleep extra. I actually felt pretty amazing. Increased talkativeness and the pressure to keep talking. So people will notice that you are, if they will notice if you're experiencing this, right, that you're talking a lot and that you're not letting them get a word in. Being around people that are manic can feel, you're going to have some counter transference to this. It could feel really overwhelming because they're just talking at you and it's not reciprocal conversation, and there's a sense of pressure, like I got to get this out. I'm not going to be stopped by anything you have to say because I have to get my point across. And it might be very distracted and tangential, which gets into this flight of ideas, racing thoughts, the subjective experience of the person feeling like their thoughts are kind of ping-ponging around in their minds, and like a pinball machine kind of, and that will make them highly distractible typically and have trouble concentrating, because clearly if your mind is kind of on fire with all these thoughts, you're going to have a little bit of trouble getting stuff done and concentrating. Goal-directed activity is pretty classic, where you will see people who, again, it's not, I want to write a book, and so I'm doing thoughtful research, and I am making a plan, and I am, talking to publishers and moving kind of at a reasonable pace. This is, I am staying up all night on a Tuesday night to write this book because it has to get written, and I don't need to sleep. And then, of course, when I write this book, everyone's going to think I'm amazing, and that can be art. I'm staying up all night to create this piece of art. It can be sexual. It can be the pursuit of impulsive sexual behaviors. So things like, I'm going to sleep with this person tonight, even though I typically wouldn't. This isn't an activity I would normally participate in, or I would normally not cheat on my partner. But tonight or right now, I'm going to make it my goal to get out there and have these sexual experiences. That gets into the involvement in high-risk activities. So someone that has multiple sexual partners, we're not going to pathologize that. But if it's not typical to their everyday life, and risky. Either it's unprotected or they could lose their relationship, or spending a lot of money gambling, buying things. I had a client once come in and I knew money was an issue. She was a sliding scale client and she came in with a brand new MacBook Air and was like, I just bought this $3,000 computer. Isn't it amazing? I want to show you. Oh, and these shoes, I have these new shoes and these new jeans. And I bought a ticket to go to San Francisco next week. Right. And I immediately knew and was able to convey to her that, because also it kind of was combined with these other symptoms, that was behavior that was new and pretty high risk for her because she just didn't have that kind of money to be spending. So that provides some context, hopefully more than just what's on the page in the DSM. Hypomania, very similar. Just remember that what it says here is it needs to last 4 consecutive days. People can live in a hypomania for months at a time because it's not going to land you in the hospital. It's not going to create such functional impairment that it's as obvious to other people and maybe yourself that there's something wrong. But you have very similar symptoms. So all of these are kind of the same as what you would see in a mania. No psychosis. I don't think the DSM criteria talks about psychosis as much, or maybe at all, which is interesting. But mania, you'll often see loss of touch with reality, and that can be within grandiosity, right? One of my clients was a poet, a writer, and then when he would get manic, it would be, I'm going to be the next best author in the United States. And that kind of turned at some point to more of a psychotic process of, I am that author. I am this person. I already am this person that you've read about. And then it was more of a psychotic process. So here in hypomania, you're not getting that. You're getting these kind of sub-threshold symptoms that are not causing the kind of impairment where they're losing their job, losing their relationships, or really getting themselves into these situations where their life is at risk. Okay. So the duration matters when you're looking at mania versus hypomania. Mania, you need a week or more or hospitalization. Hypomania 4 or more days. If you're not doing research, I don't know how unless someone came to you for assessment and they want you to be specific. I don't know in your office whether I would spend a ton of time being like, was it 4 days? Was it 5 days? You're going to get a sense based on the functional impairment of whether this is mania or hypomania. And that's when you're looking at social and occupational functioning, psychotic symptoms. Oh, here's where I have it. And hospitals, arrests. And so you're really looking at how long did this last? And more importantly, how much of a problem did this create in the person's life? Oh, did it? Oh, there we go. Okay. Depression is something I've found we get a little bit more, maybe a lot more training in depression. It is far less stigmatized. And so people talk about it more in our society. It's not that unusual for people to say, I suffer from depression. It is becoming much more common and less stigmatized, thanks to people like Selena Gomez, Catherine Zeta-Jones, and others who came out and said, I suffer from bipolar disorder. But typically depression is talked about more. And so many clinicians are more comfortable with this diagnosis. 5 or more of the following symptoms in this 2-week period. So has the person been sad and hopeless and had depressed mood for 2 weeks or more? And so you're going to see depressed mood. You need 5 or more of these for the actual specific diagnoses. But usually you see, if not all of these, then most of these. Depressed mood all day, nearly every day. People will often say, could you get out of bed? were you so depressed? And if you'll notice, getting out of bed is not really on here, because I know a lot of very high functioning depressed people that are depressed, all day, nearly every single day, but they get up and they go to work. And so they'll say, but I'm getting out of bed. I can't be that depressed. Aren't really depressed people just laying around all day? And that's not the case, actually. It's a misconception. You can be incredibly depressed and functioning. Um, Loss of interest and pleasure in activities, also called anhedonia. I used to really love seeing my friends and painting, but I just have no interest in doing that anymore. This will be a real stark comparison to the I was up all night painting because I'm going to be an amazing painter, and now I could give a care about it. I'm not interested anymore. Significant weight loss or gain, because that also comes with increased appetite or loss of appetite. People tend to think more about increased appetite, but it's just as common to have someone lose a lot of weight because they're not hungry. Changing in a significant change in sleep, either sleeping a lot or not very much at all. Psychomotor agitation, people feeling like they're moving through syrup. I've heard some really powerful analogies to like moving through molasses, or feeling like you're trying to walk and there are bricks on you. I mean, it's a real physical ailment where people will feel like they're just physically moving more slowly. And then you can have fatigue, worthlessness, or guilt. I'm such a burden on my family. Nobody wants to be around me. I'm such a loser. I feel so guilty. I didn't show up to that event because I was too depressed. Again, you're going to get some difficulty concentrating, I think, because you have all those thoughts in your mind sometimes about how worthless you are, and it's really hard. And then your brain becomes so kind of inactive and depressed that it's hard to concentrate on things. And then recurring thoughts of death and suicidal ideation can be a part of this as well. So obviously, we need to pay attention to that, because that can be incredibly dangerous for someone who's very depressed. Cyclothymia is, they want to see at least 2 years or 1 year in children where you've had hypomanic symptoms that don't meet full criteria and depressive symptoms that don't meet full criteria. This can be a little harder to suss out, but it's basically like this person has mood instability. That's how I often talk about it with psychiatrists and other people, is I'll just say there's mood instability here, but it doesn't meet the criteria of bipolar 1 or 2. And you always want to rule out substance, medication-induced symptoms, and physiological causes. So I have had clients on both of these. I've had a client who, actually a few clients who were started on an antidepressant when they were depressed, and it kicked them up to a mania, because sometimes SSRIs can do that. They can be pretty dangerous for people with mood instability. But thhad these people had not had a prior a manic episode or hypomanic episode. And once they got off of the medication, they haven't had one since. So that is a substance-induced manic episode. If it's not cyclical and continues, then you would not put them in the category of having bipolar disorder. Physiological causes, I've had clients with hypothyroidism that look pretty depressed. Hyperthyroidism can cause someone to look pretty manic. So I always refer to a general practitioner. Also, iron deficiencies people can be really slow moving and feel depressed. And so you just want to make sure that you have a team in place, not only of a psychiatrist typically, but also a general practitioner that can just look at the whole person and see if there's something else going on. Schizoaffective versus bipolar disorder. So this one can be tricky, and people kind of a lot of times are pretty overwhelmed by schizoaffective because it is an incredibly impairing disorder. What makes it different is you have psychotic symptoms. For schizoaffective, you have psychotic symptoms outside of mood episodes, right? They're not just within a mania or a depression, because both manias and depressions can cause psychotic symptoms. But with schizoaffective disorder, so it's not just the presence of a psychotic symptom, right? in schizoaffective disorder, they persist outside of the mood episode. So we give like a 2-week grace period. Like if someone's having a psychotic process during a depression or a mania, we wait 2 weeks after to see if it still persists. If it's still persisting, even when the person is outside of a mood episode, then you're in this area of schizoaffective disorder. And how is that different from schizophrenia and other psychotic disorders? Is that you have the mood disorder layered on top of that. So very difficult disorder, very difficult to assess a lot of times. I really rely on my psychiatric partners to like help me figure out that diagnosis a lot of times because it can be kind of tricky. But there are people, a lot of people I work with at UCLA that are very skilled at kind of differentiating between those two. But I think the most important thing to remember here is that as soon as there's a psychotic symptom present, that doesn't mean, oh, this is schizoaffective, this is schizophrenia or something. That can be very mood state specific. Okay, and contained within that. ADHD versus bipolar disorder. This was something that at the Child and Adolescent Mood Disorder Program was fairly common. And I can see why ADHD is often misdiagnosed with bipolar disorder. To really be tricky, they can exist at the same time. But what happens when someone or a kiddo has ADHD and is very impulsive and the hyperactive, the hyperactive form of the disorder, not the inattentive, you'll get impulsive behavior and psychomotor agitation. And being in the room with someone with a severe ADHD, many of you know, feels like they're bouncing off the walls and they're going a mile a minute and they're kind of like super distractible, and it can feel pretty manic. And so a lot of times people are like, whoa, this is definitely a mania, but they're forgetting about the mood cycles, right? What makes a bipolar disorder is the shifts in mood. And so do you have a depression here? Do you have the grandiosity and the other mood symptoms besides just energy, distractibility, and a flight of ideas? And it really matters. It matters for psychiatric intervention. My understanding and experience with clients is you don't want to put someone with bipolar disorder on a stimulant. Not a great idea. I always ask psychiatrists about that because there's changes that happen over time, and sometimes they're used in conjunction with other things. But you really want to not only to give people the accurate diagnosis, but for medical intervention, get that right. So just focus a lot on the mood and let that be the determinant for bipolar disorder versus others. Okay. This really is a very destructive and life-threatening disorder for many people. According to recent statistics from the National Alliance of Mental Health, NAMI, approximately 19% of people with this diagnosis will die by suicide. That's stunning. I actually had to recheck that statistic a couple of times because it's so high. And it is accurate that nearly 50%, so half of people with bipolar disorder, and this is not just mood instability, but if you are diagnosed with bipolar disorder, nearly half will make a suicide attempt that is non-fatal. And suicide risk is strongly associated with depression. I've never seen it with mania or hypomania. You might have an accidental something that puts your life in danger, but the suicide, I want to die, usually comes from you're coming off this mania where maybe you did some embarrassing things, you hurt your relationship, you lost your job, you embarrass yourself by emailing a bunch of people at 2 a.m. with your kind of brilliant ideas that you have. And just medically, when you come off of something like that, clients get really depressed. So it's another reason to kind of help people understand why manias aren't just something to ignore or enjoy, or, it's not that big of a deal if I don't, if I'm just hypomanic, because you will swing back on the other side of things. It's like a rubber band, it goes both ways. And often to the point where you half of people are trying to kill themselves. So keep that in mind when you're working with people, and that's why I like training on it, and why it's something I specialize in. Is it's just so important for people to get really good care. Okay. So, a correct diagnosis, I kind of talked about this. Basically, if you're doing research, like when I was up at UCLA, we got really specific and we needed to rule out people that didn't fit the diagnostic criteria 100%. In your practices and your day-to-day work, if it's a symptom off, one symptom off, or it feels a little confusing, the way they're going to treat, psychiatrists are going to treat it psychiatrically, medically, is pretty similar, if not the same. And as long as you are kind of within the areas that I've talked about, and there's functional and social impairment, it's going to be a thing that you're going to want to treat. So I wouldn't get too hung up if there's like a symptom here or there, or you're not sure if it's 4 days or 5 days. Okay. So I feel like I fly through this stuff because there's so much stuff to get through, but I went over the criteria. So sometimes for me, and I think for a lot of clinicians, you read the DSM and then you're like, okay, cool. What do I say in the room? You can just whip out the DSM and be like, okay, do we have this, 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 this? But when I was doing structured clinical interviews, I gathered some language that I then took with me into private practice that is really helpful in getting people to give you accurate diagnostic answers. They're specifically written for validity. So these are questions that help people actually answer the question accurately, which is why they're a part of these, well-developed and researched clinical interviews. I kind of just talked about that. Okay. So for mania, have you ever had a period of time when you felt so high, hyper excited that you just didn't feel like your normal self, or maybe you got yourself into trouble? I said that phrase hundreds of times as I was calling people or interviewing them in person up at UCLA. Have you ever had a period of time when you felt so high, hyper, or excited that you just didn't feel like your normal self? Or maybe you even got yourself into trouble. People that have been diagnosed with bipolar disorder or have experienced this will immediately know what you're talking about, usually. Like, oh, yeah, my manias. Or they'll say, yeah, I sometimes I'm just not myself and I'm just like on one and I get like super excited and everyone around me is like, what are you doing? And what are you taking? And then I don't sleep. And typically that's enough to elicit a pretty accurate answer. And then you also want to say, don't forget the irritability and anger one. Have you ever had a period of time when you were so irritable and angry that you weren't your normal self? And I would actually add, and maybe got yourself into trouble. So sometimes when I have more time, I like to role play with people. And what I'll do is I'll have someone ask me that question. And in one version, I answer when it is not so much a mood disorder. So for the first one, have I ever felt high, hyper excited? I might say, yeah, I gave a presentation the other day and I felt really proud of myself. And the rest of the day, I just felt so happy and excited. That's not mania or hypomania, right? You can ask some more questions about it, but you're looking for an answer that's like, yeah, there are these times in my life when I get so revved up, when I get so excited about something or locked into something or driven by something that I'm almost like I'm driven by a motor. I'm just go, go, go. And I talk a lot and people in my life notice it. And so then you're going to want to ask more questions when you get those types of answers. I like to follow up with, can you tell me about the most recent time or a time that really sticks out in your mind? I want them to put themselves back into one of these times they're talking about. So then I can ask questions about the other diagnostic criteria and they're thinking about a specific period of time in their life. So they're able to give me better answers. Okay. For depression, Have you ever had a time when you felt sad, down, or depressed for most of the day, nearly every day? And can you remember the longest period like that? Or can you remember a recent time when it lasted more than 2 weeks? If people say, yeah, I was really bummed out, for a day or two, but it never really lasts longer than that, you're not in depression territory. If it's, yeah, I get into it's like weeks at a time when I'm super depressed, or months, then you're going to want to ask those follow up questions using the DSM as your guide. Here's what I don't get into in this presentation that I realized this morning as I was flipping through it. I should talk more about mixed states, because you will get people who have a mixed state episode where within a period of time, a week or a month, they are experiencing manic symptoms while they are also depressed. This is harder to treat. It's much harder, for people to experience. It's much more difficult. And people tend to use more words like, I feel crazy, or I don't know what my mind is doing, and I'm super confused because I'm kind of motivated and excited and high and hyper, but then like 10 minutes later or a day later, I'm just totally depressed. And this is I think probably less common, but I've also heard it's happening at the same time, Sarah. Like my mind is going and I'm thinking all these things and having all these experiences that correlate with mania, but I also there's a part of me that's just depressed and super aware that all that stuff's never going to happen. And so you might get a mixed state. And that is, you're going to want to consult with a psychiatrist that specializes in this. You can consult with me anytime. I do consultations or second opinion assessments a lot. But I should talk more about mixed states. And I realized I didn't have a slide about that. Every time you assess for a depressive episode, you always assess for a period of elevated mood. This is one of the biggest problems, challenges, things that's happening in our clinics and our private practice offices that could be really problematic, because you will meet people in their depressive episode. Really rare that someone who's in a mania or hypomania is going to come in for treatment. They don't need it. They're doing great. Everything in their life is great. Don't want to hold them down, right? But when they're depressed, that's when they'll come in to see you. And if it's only treated as depression, first of all, they could be put on a medication that would be dangerous, but you'll miss the diagnosis. And so every time someone comes in for depression, you always want to ask about that. Have you ever had a period of time when you were high, hyper excited? You're going to want to understand what happened leading up to the depression, because a lot of times that's missed. Okay, I'm keeping an eye on my time, but I always like a case study. So enough of this has been changed that it would not be a concern of anyone knowing who this person is. Alice, 20-year-old African-American female, history of severe physical abuse in her household, grew up in a really poor area outside of Chicago, got a scholarship to Harvard, and really, really bright young woman. So much promise, so much opportunity. And so goes off to Harvard on a scholarship, full ride scholarship, and gets there. And there are a lot of factors at play as to why it starts to feel pretty uncomfortable for her there. She starts to feel kind of small or less than. And so she has a depression early on, about feeling out of place, feeling like she doesn't deserve to be there. But also at a certain point, she dropped out of school sophomore year due to this severe depression, and I saw her for this period of time at a clinic. I never asked if anything weird or unusual had happened to her before the depression. It was just, keeping her from killing herself, quite honestly, and giving her tons of support around this depression. Later, I find out that she had like these weird moments before, when she first got to school, where she would feel like she was all powerful, where she would feel like she could maybe change the weather, where she would feel like she could get an A in any class that she wanted to just without even going to the class. So she'd have these like periods of time where things were obviously different, but never thought to really bring them up. And I think was kind of embarrassed about it. So, um, never brought it up until I started to notice her mood elevating in session with me. Now, people ask me a lot, what's the psychodynamic meaning of mania? Is there meaning to this? Or is it just a medical disorder? And what I believe to be true, and I think what the research really shows, is that it's both. There is environmental significance. You have a genetic predisposition to something, and some trauma kind of comes along and, like unlocks it. And so maybe you were predisposed, but when you go through severe physical abuse as a child, and when you get into an environment where you feel very small and unwanted, what happens? Your mind almost kind of tries to protect you in a way. This is more of a psychodynamic conceptualization, but you'll get people where she felt really small and powerless. So, what happens when she's manic? I am powerful. She actually believed she was white in a lot of her manias, because she kind of went on to have a couple of manic episodes and depressions. And when she was manic, no one could stop her, no one could hurt her, incredibly angry um, at her family for having hurt her, incredibly angry at anyone she thought was judging her or might. So there was a paranoia in it where she would come into my office and say, you're going to hurt me. I know you're going to hurt me, but you can't touch me. I'm untouchable. So there was real meaning in these. Just like a lot of people who never felt sexy or attractive when they're manic engage in really impulsive sexual activity. A lot of people that grow up poor end up buying a lot of stuff when they're manic. There's not always a one-to-one comparison there or connection, but oftentimes when you stabilize someone and you get them, euthymic and on the proper medications typically, then you can start to, I wouldn't dig around for the meaning when they're, flailing and in need of support, right? Or intervention. But once things are stabilized, you can go back and be like, what do you think of the way that your mania presented itself? Seems to me to maybe be tied to experiences you've been through, traumas you've been through in your life. I had one client once who went through a real brutal sexual assault. And when she was manic, she would go into bars and places and just start throwing punches, just start, F you, you can't hurt me. I'm going to hurt you. And just that irritability that also came along with all those other symptoms, not just irritability in and of itself. But during her manias, she would have these rage outbursts, and I got it. Like, I understood where that came from, and she could have self-compassion and time and understand where that came from. So remember that bipolar 2 is often bipolar 2 is often overlooked, underdiagnosed, because I don't know about your educational experiences. In mine, when you're in psychopathology class, they teach to the most extreme version of the disorder, which I get, and you only have so much time, right? Like, I only have so much time here, but bipolar disorder gets misunderstood as like the most severe form of the disorder, to the point where someone in my class once said, I'm seeing someone who's a dentist and they were diagnosed with bipolar disorder. What do you think our obligation is to tell their patients? And it was like, whoa, why would you make the assumption that because of that diagnosis, you can't be functional? Most of my clients I see in private practice are more in the bipolar 2, some are in the bipolar 1, medicated, high functioning. You might not ever know that it's something that they dealt with. Only their friends and family know. And it's very much left in their past and have occasional brief relapses. But there's definitely a whole world of people with this diagnosis that are incredibly high functioning. It's also overlooked because a lot of people during hypomanias are like killing it at work. They're doing great, and everyone's telling them, they're getting promotions. And if they're in sales or anything like that, they can sell anyone anything because they're very charismatic. And then maybe they go home and then they hide their depressions from people. But a lot of times it's a hard sell to get someone to understand that the things that are working very well for them at work and maybe causing other people to be very attracted to them are also the things that are leading to their depressions and a part of a hypomania. Okay, I want to leave some time here. You'll get this presentation, but here's some risk factors. You want to know that family history and um, um, you know, genetic predispositions, are often passed down within families. So if you have parents with bipolar disorder or a mood disorder, that child is more likely to have one. It doesn't mean that that child will have one. It's actually more likely that they won't than will. But what it's saying is they would have a higher chance for it. Stress, obviously, big risk factor. I encourage people to de-stress their lives as much as possible within the realm of, boy, do we live in a stressful world right now. So there's like a reality piece to that, but getting good sleep, having a routine, staying out of family conflict or relational conflict when you can, and substance abuse. A lot of people self-medicate, especially before they're appropriately diagnosed. So cocaine would maybe bring you up from a depression, alcohol would bring you down from a mania. And those things are going to interfere with prescribed medications as well, maybe be very dangerous. So here is the treatment section. And what I want to do here is just go over, appropriate diagnosis provides a roadmap. And I talk about treatment in Cal Psychiatry has a podcast called Mind Stories. And if you look up my name and Mind Stories, I focus specifically on treatment. So it's going to go over what I don't really have time to go over today because I focused on diagnostics and assessment mostly. But essentially, it talks about processing a diagnosis, thinking of this as a recovery model. The goal is not to ever have another mood episode. The goal is to learn from them, understand your triggers, create a mood chart so you can know yourself well enough to know when you're at a 2 or a 3 of a mood episode to keep yourself from getting to a 7, 8, 9, 10, right? And there's a whole nuance to how you help people understand this disorder and depathologize it and all of that. You're also really going to be needed as a mirror to someone's experience. What are you hearing? What are you seeing? Can you provide that back to the person? I'm noticing you're talking a lot. I'm noticing you're engaging in these goal-oriented activities again. Really non-judgmental, really loving and supporting way of letting people know what you're seeing, just in case they're in it and they can't see it themselves. Sleep hygiene, support groups, all very important. Medication is a very important part of this for many people. In that podcast, I talk about helping people understand the risks and rewards to medication, far more rewards than risks for most people. There are medications and medication regimes out there, regimens that don't have a ton of side effects, but some people will experience side effects. There's also this myth that you lose creativity. And there's definitely like, look, you're not going to have access to the manic, hypomanic parts of your brain, but also you're not probably going to get these depressions, right? So let's keep that in mind. But most people aren't at their best creatively and they're most functional and they're most productive when they're manic. They might feel like it, but you have to address this myth of like, now I'm boring. I can't do anything because I'm not manic anymore. That doesn't tend to be true for most people. But you'll hear that a lot. I don't want to be dull. I don't want to be numb. I don't want people to be numb and dull and not feel anything either. But those aren't the two options, right? There's a lot of gray area in between there. Here are some resources. So I'll just leave you guys with those on those slides. You have clinics and people and IOPs and support groups and literature that you can read. And then also, here are some people you can reach out to. A couple of my favorite psychiatrists, clinics, and you can reach out to me anytime. I provide consultations, supervision, second opinion diagnostics assessments, And you can even just say, like, I'm stuck. I'm having most of my calls from colleagues are like, I'm stuck. I'm having trouble um, knowing where to go next. Or I just want to make sure that what I'm seeing here really is bipolar disorder as opposed to something else. So I'm always happy to hear from you. I have left 5 minutes if you have to leave at 10, but I can say, excuse me, until 10:15, 10:30, or 10:15 or 10:20 to answer additional questions that anyone might have. So I don't know if I should go through. I see some here. Maybe I start with what? Oh, actually, I see one here.
Yeah, you have some up there. And
Mm-hmm.
just for anyone who has to leave early, I put the link to this presentation of ShrinkSync, and I uploaded the slides, the YouTube video we discussed, and the evaluation form, and I'll add the recording as soon as it's available later today. But yeah,
Yes,
go ahead
and
and go through the questions.
I think it's Dahlia. I agree with you that 1 hour is not enough time for this topic. Oftentimes, it's a 2-hour presentation, and that's why, in your evaluations or reach out to me. Please ask me questions. Please don't feel like if you didn't get it in today, you can't, email me a question, because I'm always happy to talk about this stuff. But you're right. I just feel like I'm a little manic trying to get through, not, to be dismissive of that term, but trying to get through. I talk very quickly, and I know that sometimes that can be a lot to take in. So I hear you. There was a question that says, can you talk a little more about bipolar disorder in children? I can, and it absolutely can be made, this diagnosis, and it's important that it is made. In the Child and Adolescent Mood Disorder program at UCLA, we would see people kind of 8 years old and up. And you'd look for depression. There's actually an article that I wrote. You can Google my name and depression in children, and it talks about the kind of irritability, the somatic symptoms that can come along with that. So you might see more headaches, stomach aches coming home from school, really irritable. And it's often just described as like kids are difficult. But this is something that's obviously like more than that. You would know if your kid was talking about not wanting to go to school, hating themselves, feeling like they're good for nothing, really bad stomach aches. The gastroenterologist and general practitioner is like, look, this isn't anything I can diagnose. There's something else going on. And then the hypomanias, I see, I wish I knew the research on this. I really don't, but I see less of that in kids. And I don't know whether that's underdiagnosis or whether it's just less frequent. I'm going to look into that and I can let you know. But I see less in like little kids of that hypomania mania. And then when you get into adolescent and teen, then yes, a lot of people will have their first episodes in their late teens, early 20s. That's when you tend to see this stuff kind of surface. Women tend to have their first episode be a depression. Men and boys, it's often a mania that's the first episode, which is interesting. Again, I don't know if that's just underdiagnosis of depression in boys, but so you can see it, adolescents and teen, I see it as more of the full presentation of it. But kids, there are ways specifically to ask appropriate questions to get the right diagnosis. And the Child and Adolescent Mood Disorder program is a great place to go. And that article that I wrote about that topic is available online too. Okay. If someone was diagnosed with bipolar and tried several meds in younger years and said they did not help, so won't take meds, any tips for this? Perhaps client not bipolar if meds didn't help. So yeah, in general, medication can be a real controversial topic, hot topic, difficult topic for teens and adults. A lot of times they cause side effects. You can have people where there's weight gain, or they do have some sort of emotional kind of, they don't feel like they're a little bit dulled. They don't feel like they're their full creative self. there's a reality to that. Or, if you go on lithium and your doctor says, don't drink a lot because there's a risk of dehydration here, people will still want to drink. So some of this comes down to what the person's priority is. Oftentimes, I've found that when a young person lives a little bit more of life and has more ups and downs, then they realize, okay, maybe some of those side effects are worth it because I've now lived through so many of these ups and downs that I'm now ready to take the steps to level myself out a little bit more. Um, Young people often don't want to be told this is a chronic illness. You're going to be maybe on medication for the rest of your life. So that's a harder sell too. So my way I approach medication, and for this particular client, if they say they never worked, I don't know what happened in their past, right? And I don't know what medications they tried or didn't try. What I will say to them is, this is the diagnosis. If they meet the diagnosis, I'll say this is the diagnosis. What we know is that if you have one episode in your life, you're more likely to have another than not. And for most people, medication is what keeps them, whether it's lithium or anticonvulsants, or sometimes an anticonvulsant with like a mood stabilizer with a atypical antipsychotic. For most people, that prevents future episodes when taken consistently. And also not taking drugs and not drinking alcohol, which sometimes young people don't want to stop doing. So I'm really collaborative, and I say, this is what we know. So if it were up to me and my whole goal was to keep you from having another episode, I would 100% tell you to take your medication and not engage in drinking and drugs. That said, we're not going to get anywhere here if you aren't on board with this, or if you started to lie to me about your behavior because you thought I didn't approve or anything like that. This is your life. And so if, maybe for this client, maybe a second opinion is needed, or getting them with another psychiatrist that could maybe help them a little bit more or differently. But just broadly, the idea of medication is, I'm not going to be the one that tells you have to do this, especially with a younger person. I'm just going to tell you the risk and the risk factors. And I'm really going to be clear about the risk factors associated with depressions and suicidality, and just say, we can see how this goes for you. If you've had a significant episode in the past, it's likely that you'll have another, but we can see how this goes for you. And in time, if you decide that the medications are worth retrying again, then we'll do that together. But I'm not someone who says you have to be medicated to see me. I'm just going to highlight for you, if you're in and out of the hospital, kind of recovery related, a recovery model, motivational interviewing type of technique of, kind of when is enough, right? And if people go through this enough in their lives, typically they say, okay, I'm willing to try medications again. They have much newer medications now than they even did 10 years ago too. So if someone older came to me and said, I tried stuff as a kid and it didn't help, I don't know, maybe your chemistry changed, or maybe the medications have changed. So I would just start with what we know now and go from there. The person is afraid, a young man. I would just really normalize that. I would normalize the fear of medications. I would also share that there's a lot of misinformation online. Don't ever get the information from Google or chat groups or Reddit. I think that people that are more likely to go on those forums are the people that have had really awful experiences. I think it's pretty rare that someone goes on and is like, I'm on lithium and it changed my life and things are going really great for me. And, sure, I've had a couple of episodes, but by and large, I've been level. That's not usually what you get. You usually get a lot of people that have had bad experiences. And so I'd normalize the fear, get them with a psychiatrist like the two named here, or I can give plenty of other options that can listen to their concerns. And then together they can decide, look, just because you meet with a psychiatrist doesn't mean you have to take medication. It just means you're armed with more information. And then we can see, you can also go off medications if you hate them. It's not a forever type of a deal. So yeah, hopefully I answered that question. Anything else?
I love that you have Cal Psychiatry as one of your resources because I'm a huge fan and I share so many clients with them.
Mm-hmm. Yeah, Josephine was the one that did the podcast with me, and she and I, we talk about the medication issue. We talk about meeting a client where they're at, and not being like heavy-handed about stuff, especially with college kids. We'll see a lot of college kids right after their first episode
Mhm.
saying like, I don't want to sign on for this being a chronic illness. You can't predict the future. You don't know, Sarah, that this is what this
Mhm.
is. Maybe I was just on shrooms that one time and had an episode. And it's like, yeah, maybe you were. Let's see how this goes. I'm here. I'm along for the ride. I'll support you. I'll support you unconditionally, and we will figure out what this is together. Um, Meeting a client where they're at is always
Yeah.
the right way to go.
I can imagine that there's a lot of, I don't know if denial is the right word, but after just a first episode, not wanting to accept or subscribe that this is what the rest of your life is going to look like.
Oh my gosh, of course. And when it's young people, a lot of times there are drugs and alcohol,
Mhm.
involved. It's involvement in that. So you don't really know, and sometimes they never go on to have another manic episode. But yeah, I get it. It's being told you have a chronic illness and can be relieving and also destigmatizing. But I think especially for young people, it can be really daunting, and I'm not going to hit you over the head with that. And I don't know the future. And truthfully, I don't think it's necessary for people to identify with the disorder and call themselves, I'm bipolar or I have bipolar disorder. If they don't want to, we can call it whatever you want to call it, your ups and downs, but I, as the clinician in the room, owe you an accurate diagnosis. I owe you the research. I owe you the what typically happens for people in your situation. But you are you, and we can see how it goes. But so it's kind of I get to be the one to say, as the expert in the room here, let me tell you what I have seen and what I know to be true. You are the expert on you, so we're going to meet somewhere and we're going to figure out what this is together.
I love that. Thank you so much. This was so helpful and informative. If anybody has a last minute question, go ahead and type it in. But I love that you've put your phone number and your email address as a resource and um, consult with other clinicians on this. Um, I put up the link, but if anybody goes to shrinksync.com/ open mic, OPENMIC, the first presentation listed there is this one on bipolar disorder. And I'll put up the video recording as soon as it's available in the next couple hours. It has the slides, the video, and the evaluation form. So thank you so much. This was so great.
Of course. And I really encourage everyone to be as honest as they can. I give this presentation a lot, and it's really helpful for me to hear what worked, what didn't work, what was confusing. And there have been times when people have said, hey, I didn't really love the way you said that thing, or I felt this was kind of pathologizing, or that's not my experience of it. And I really welcome that too, because it just helps me learn and grow and become a better presenter and therapist. So,
Love that.
yeah,
Thank you so much for joining us.
you're
Enjoy the
welcome.
rest of
Thanks for
your
having
weekend.
me.
Yeah.
Thanks. You all too. Take care of yourselves. This is a tough
Bye.
job. So make sure you're engaging in self care.
Bye, everyone.